Good afternoon, this is Iremba Wilfred, and today's lesson we are going to look at pain, which is among the conditions that we look at in palliative care. So today we are going to cover pain as far as palliative care is concerned, and we are going to deal with it in the following objectives. 1. We shall have to define what we mean by pain. Number 2, we shall mention or discuss about several causes of pain. And number 3, we shall look at types of pain. And then we shall look at the classification of pain. And number 5, we shall see how we can manage pain. And then lastly, number 6, we shall look at the principles of managing pain. So allow me to take you through the definition of pain. Pain is an unpleasant sensory or emotional experience associated with actual or partial tissue damage. That is according to World Health Organization. Other researchers can define pain as anything that someone complains of that hurts most. Others, they say it is an unpleasant sensation which is hurting most. Those are different definitions of pain. And when you look at the causes of pain, practically I would say you would pinch your neighbor and then you see the reaction that the neighbor is going to show to you, and that will indicate that that person is in pain. There are many ways that we can show when you're in pain. But basically here I want us to understand the causes of pain, and these I group them into different causes. 1, we talk about physical causes. What do you mean by physical causes? Physical causes could be trauma, could be pain following an RTA. Physically, someone is feeling that pain, and that is under a physical cause. Number 2, there could be psychological causes. A lot of thoughts, a lot of anxiety, a lot of stress. Psychologically, someone feels or expresses pain. There could be social pain. Remember, in the community, sometimes you can be stressed because of the community that you are staying with. Those are some of the social pain. Probably maybe in your community you're staying in, people are not interested in seeing you, or you're not also interested in talking to them, and you find that socially you are experiencing that category of pain, and it becomes among the causes of pain. Others could be spiritual pain. I understand many people go under this. Whenever you hear someone talk about your religion, however you see people are complaining about different religions, spiritually it affects them, and it becomes also among the causes of pain. Political causes. Politically, you know what I mean here. Politics. Okay. This could be secondary to like voting, could be war, could be maybe a country is not in good term with another country. Politically, it also comes in like that. So we will also look at surgeries. Also, those are some of the causes of pain. Whenever someone is going into surgery, they also express that pain. So when you look at causes of pain, we group them into those different subheadings so that you can know that pain is not only caused by a single thing. The types of pain, basically we have 2, and 1, we have acute or chronic. That is type number 1. Pain can be acute or it can be chronic. And number 2, it can be neuropathic or nociceptive. We shall understand what we mean by neuropathic or nociceptive. Other books, they categorize them into, they can say it is cancer related type of pain and non-cancer related type of pain. But basically when you look at them, cancer related type of pain, most of them, they are chronic. So it is either acute or a chronic type of pain. So when we talk about neuropathic pains, this involves damage to the nervous system. If the pathways of the nerves is damaged, then someone goes under what you call neuropathic type of pain. And when you talk about nociceptive pain, the nerves are intact, okay? They are not damaged, but these pains are originating from either the muscles, or they're originating from the skin, or they're originating from the bones. The nerves are completely intact and they are not damaged. So objective number 4, I said we shall also discuss about the classifications of pain. And pain is classified into different categories basing on a certain factor. Factor number 1, we classify pain basing on the duration. The duration, the time it takes. It can either be acute or chronic type of pain. That is classification number 1. Basing on duration. So basing on duration, it has 2. It is either acute or it is chronic. Acute, this is a type of pain which is less than 30 days. And then chronic, this is a type of pain that has been there for more than 30 days. Other books, they say for more than 60 days. Classification number 2, we classify pain basing on the etiology, or basing on the cause. And the cause here we look at either cancer related or a non-cancer related type of pain. So that is the etiology. If the pain is resulting from cancer related conditions, then it is cancer related type of pain. If it is not a cancer type, okay, then we say it is a non-cancer type of pain. Classification number 3, we classify pain basing on opioid response. Remember, there are some pain that may not respond to opioids, and those pains that may respond easily to opioids. So we have non-opioid respondent pains and opioid respondent pains. Those are 2 classes under a classification of pain basing on opioid response, or pain responding to opioids. And then we further classify pain basing on the intensity. And here the intensity, it means the pain may be mild, it may be moderate, it may be moderately severe, it may be severe, and sometimes it can be overwhelming. And when we say overwhelming, this means the pain is extremely very severe. This is why someone cannot be able to sleep because of pain, cannot do anything for himself, and cannot even feed himself because of severe pain. And how do you know this, that someone is in severe pain or overwhelming pain? This person will be crying, okay? Then we classify pain basing on the totality. And when you look at the totality, total pain, okay? Pain can be physical pain, can be psychological pain, it can be social pain, it can be spiritual pain. Those are the 4 dimensions of pain, and these we put them under total category of pain. That is a class of totality. And still pain can be classified based on the origin. The origin here we mean pain may be superficial or it may be deep. Usually superficial, they are easily localized. You touch, or when you want to touch, someone tells you themselves don't touch. Or in other words, the person is responding to before even you touch. And sometimes you can touch and then someone tells you, I'm feeling pain. That is a superficial type of pain. And then the deep type of pain, usually those are poorly localized. Okay, deep means the pain is originating from deep muscles or deep organs, and that is a classification of pain basing on the origin. And then we can further classify pain basing on the location. This is where you find someone is complaining of headache, that means the pain is on the head. Someone complains of backache, it means the pain is at the back. Someone complains of joint pains, it means the joints is where the pain is originating from. So basing on the location, it gives us varieties of these pains. So how can we manage pain? Before you manage pain, we need to understand that you need to assess the pain, and then you can know the category of pain you are dealing with. Okay, so we are going to assess, and then you'll be able to classify your pain. And how do we assess pain? How do we assess the severity of pain? Here we take what you call a PQRST. PQRST. What is P? These are precipitating factors. Okay. Other books they can say perpetuating factors, predisposing factors. These are factors that actually making pain more severe. Okay. Then Q is the quality of pain. Is it severe? Is it mild? Is it moderate? Quality of pain. We are looking at how severe the pain is. Is it making you not sleep? Is it stopping you from feeding yourself, from carrying out the daily activities? And then R stands for relieving factors. You ask the patient, when pain comes in, what do you do? What can you do to relieve this pain? And the patient will be able to tell you, I can't sleep, I can take a lot of water, I can make myself busy, but sometimes it cannot work, and then I will opt to get a simple analgesic, or even a simple analgesic may fail, and then I end up getting a strong analgesic. T stands for time. In other words, at what time does the pain come? Does it come in the morning? Does it come in the afternoon? Does it come in the evening? Or it is on and off all the time? Time. And then S stands for sites. This gives us the category of pain that someone is having. Sites, we mean someone can complain of headache, and at the same time someone can complain of backache, at the same time someone can complain of abdominal pain. Those are different sites, and these sites, when we go into deep details, we shall realize that this pain these people are complaining of, they are either nociceptive pains or neuropathic pains. Because when you go into deep details of nociceptive pain is further classified into other categories of pain. Nociceptive pain is categorized into two, or classified into two. One, we have what we call somatic pains. Somatic pain, this is a type of pain that originates from muscles, that originates from the skin, and originates from the bones. As earlier on we had said, nociceptive pain, this is where the vein, this is where the nerves are intact, they are not damaged at any time. For them, the nerve pathways are functioning normally, but this pain is originating basically from the muscles, from the skin and from the bones. And then the second category, or the second class under nociceptive pain, we have what we call visceral pains. And visceral pains, these are types of pains that originate from deep organs, and these pains are usually poorly localized. You can tell someone to show you exactly where the pain is, but the person will not be able to clearly touch where the pain is. Someone will touch and tell you pain is here, but it is coming from deep inside, meaning that it is originating from the internal organs. So that is what we mean by nociceptive pain. And by talking about nociceptive pain, this gives us the type or the nature of the pain we are going to manage. And as earlier on we still said, neuropathic pains, this is when the nerves are damaged. And how do we classify the neuropathic pains? Usually we look at the three types of nerve system. We have the autonomic nervous system, we have the peripheral nervous system, and we have the central nervous system. Now when you look at the peripheral nervous system, it is composed of two major parts. We have the sensory and the motor. Okay, that is the peripheral, because we are aware that for a system it must have a starting end and the ending end of it. The sensory part of it is a part that is stimulated, that receives information, and then it sends the information for interpretation. After being interpreted, then the information should be able to come back. That is a positive feedback, and then someone will be able to withdraw himself or herself from the site of pain. And then when you look at the central nervous system, is composed basically of it is composed basically of the spinal cord and the brain, and usually when those two are also damaged, then the pain is categorized under the central nervous system. Then we talked about the autonomic nervous system, and the autonomic nervous system, it is also composed of two, where we have the parasympathetic and the sympathetic. So as we have known that these pains can be classified into those categories of pains, then it gives us the way we can handle or we can manage the pains. And basically, when you look at the way we are going to handle these pains, we shall look at the principles, or we base at the principles that we look at as we are managing pain. And basically there are four principles. Principle number one is by clock. By clock, it means usually when we are using analgesic ladder, we shall give that painkiller or that treatment at a specific time by clock. Okay, and then principle number two is by mouth. Principle number three is by patient, and then principle number four is by ladder. And when we say by ladder, this is when we are going to talk about the three-step analgesic ladder. So those are the principles that we always talk about as we are going to manage pain. And basically pain is managed in two ways. One, we manage pain using pharmacological management or pharmacological measures, and the second category of how we can manage pain is a non-pharmacological management. And when you basically talk about pharmacological management, this is where we are talking about drugs, use of analgesics. And this use of analgesics, they are given depending on the severity of pain. Remember, we said pain, it can be mild, it can be moderate, it can be severe. I hope you still remember that. Now, these are the three steps that we are going to look at as we are dealing with the pharmacological management of pain. Step number one, This is where we use simple analgesics, and basically we use the non-steroidal anti-inflammatory drugs. And what are the examples of these non-steroidal anti-inflammatory drugs? We have aspirin, we have paracetamol, okay, we have ibuprofen, to mention but a few. Those are some of the simple analgesics, and when you look at them, they are non-opioids, meaning that on step 1 we are looking at a mild type of pain which will require a non-opioid drugs. And non-opioid drugs, I'm saying these are simple analgesics, and usually simple analgesics, we are looking basically at non-steroidal anti-inflammatory drugs. Listen, on step number 1 we have another category of drugs which we call adjuvants. And usually adjuvants, they work as analgesics, but when they are not analgesics, okay, they exercise the powers of working as if they are analgesics, but when they are not analgesics. And good examples of adjuvants, we have antidepressants, okay. For example, the commonest antidepressant we always give is amitriptyline. And amitriptyline, you know, each tablet is 25 milligrams, and that is a good example that we give under antidepressants. Another category of adjuvant, we have steroids. For example, dexamethasone, prednisolone, to mention but a few. Remember, when we give those ones, they reduce the swelling. If there is a swelling, they will have to reduce on those swellings, and many others. Those are the few examples of adjuvants. So step number 1, after giving what we have discussed, non-steroidal anti-inflammatory drugs, then you can add on, or you may not add on, adjuvants. Step number 2, this is a moderate type of pain. Moderate, it means the pain is more severe than the mild type. Yes, the mild type. And here we use weak opioids. Now we are starting the opioid route, and opioids are class A drugs. And the examples that we can give under these weak opioids, we have codeine, we have tramadol, we have dihydrocodeine. Those are weak opioids which we give on step number 2. And step number 2, we are saying it is a moderate category of pain. Now step number 2 can be added on step number 1. Remember what we said on step number 1. Step number 1, it also has an addition, meaning that we can add step number 1 to step number 2. Okay? Now step number 1 to step number 2. Step number 1, they are non-opioids, but step number 2, they are opioids. So this means they can be added together, plus or minus adjuvants. And then step number 3, this is where we have severe pain, meaning that the pain is too severe for the patient. And here we are going to use strong opioids. Now what are the good examples of strong opioids? Here basically we use morphine. And morphine is a class A drug. Remember, opioids, they are class A drugs, and these drugs are kept under key and lock cupboard, meaning they're supposed to be kept in a double locked cupboard. Step number 3, where we are having severe pain, it can also be added on step number 1. Now the question is, why shouldn't we add step number 2 to step number 3? This is simple. Step number 2, we talked about opioids, and step number 3, still they are opioids. So we cannot combine opioids, because remember, the opioids, they have serious side effects, and one of the commonest side effects of these opioids is constipation. Now, if you give an opioid adding it on another opioid, this patient is likely to develop severe constipation. And when he develops severe constipation, then the person may end up developing fecal impaction, which will be again a complication that is resulting from poor management or poor additional of analgesics under a 3-step analgesic ladder. Therefore, step number 3 should be added on or may not also be added